The coordinators for this session will be Dr. Sashita Sir, Dr. Ravi, as well as Dr. Jessica, who will be heading this session. The first topic for today will be by Dr. Hiteshri ma'am. Over to Dr. Jessica.
Good afternoon, everyone. I welcome you all to the Retina session. I'm Dr. Jessica, and I'll be moderating the session. Our first topic is examination and documentation of retinal disorders. It will be presented by Dr. Hiteshri, a consultant at Minto Ophthalmic Hospital.
Warm greeting to all. I'm Dr. Hiteshri from Minto Ophthalmic Hospital. I would like to thank KOS, Dr. Elan Kumaran sir and Dr. Nagaraju sir for this opportunity. So my topic is indirect ophthalmoscopy and documentation. Let's take a quick check on the idea of fundus examination. We need a well-dilated pupil, patient in reclining position. Hold the condensing lens with wide thumb towards the patient. Direct the ideal light to the eye without the lens. Asking the patient to look up, then bring the lens in. The third or the fourth finger extended, acting as a pivot. Let's see the technique. So check the aperture of the IDO for the light spot. Then tighten headband comfortably over your head. Adjust the interpupillary distance so as to obtain the centration of the light spot. Using not that too much bright light illumination, start from the superior periphery of the retina. Complete all the meridians in a continuous manner with each quadrant to be examined along the course of the vessels. You can use the patient's thumb or the extended arm as a pointer for the patient fixation point. And we have to end with the scleral indentation for the aura. Then that is when you ask the patient to look in the direction in the opposite to that of interest, and the indenter is placed tangential. The indenter is placed over the lid crease and pressure is applied tangential. When I'm asking the patient to look towards the direction of interest, the aura is visualized. You do it for 360 degrees. So the disadvantage here is IDO gives an inverted image, which is the reason for confusion for a lot of people in the beginning. So one thing to remember, whatever direction you are focusing, that is the part of the retina you're viewing. Superiotemporal you're focusing, you're viewing superiotemporal retina. So you start from one meridian in a continuous manner and overlapping manners, see all the meridians in the periphery, then you come to the center with the further disc and the macula for patient comfort. So how do we transpose this onto the fundus chart or the fundus drawing? It is done on the Amsler-Dubio chart, 3 lines, the equator. This is the second one is the aura, and third is the pars plana pars pectora junction. So you have 2 circles for macula and disc interchangeable for the right and the left eye. The aura, the narrowest nasally, also these. See, the dentate processes are more marked on the nasal retina. This has to be put on the chart. Normal fundus, see the dentate process marked on the nasal retina. So you are standing towards the head end of the patient. So how do you get your lesions on the chart? You have to place the chart inverted over the patient's chest or by the side of the patient, so that the 6 o'clock meridian of the chart is towards the patient's head. Now we know that the fundus image in the condensing lens will be inverted upside down as well as right to left, that is laterally reversed. So keeping the drawing in reverse position gives us the same orientation as this. So if we merely transfer what we are seeing onto the meridian, we get the fundus chart right. So what you have to do, you stand at 180 degree opposite to the part of the retina that you are interested. That is the 1 o'clock meridian, you have to stand at 7 o'clock. See, in the chart, you are standing closest to the 1 o'clock meridian, that is the area of interest. What we do, we just write what is seen in the condensing lens image onto the area of the meridian that is closest to us without thinking superior, inferior, nothing. Just write it where is the closest meridian. And you go from the disc along the vessel to the periphery. In the same way, transfer it onto the disc at the closest meridian and complete the fundus charting in all the meridians. So what is the color coding that has to be followed? This is the one, we'll take it one by one. So the red solid line, this is for retinal arterioles, neovascularizations. hemorrhages, pre-retinal, intraretinal, vascular anomalies, vascular tumors, and inside of the retinal breaks, inside of the retinal hole that is in the outer layer of the retinoschisis. So red cross line, this is for the open portion of GRT or large dialysis. The open portion of the hole in the inner layer of the retinoschisis or inside the CRA patch. Blue solid for retinal vein, detached retina, outlines of the retinal breaks. Inside will be blue cross. The ora serrata, these are the retinal cysts, intraretinal cysts, outside outline of the thin edge of retina. So blue cross lines, this is for white without pressure and the rolled edges of the giant retinal tear or the retinoschisis. So anything in front of the retina is given a green color. It can be vitreous membranes, vitreous hemorrhage. If it's fresh, you can border with the red color. V-ring. Okay. Any intraocular foreign bodies or like the IOL, vitreous substitutes, silicone oil, and these opacities in the media. Also, the elevated new NVE will be given a border of green. Green dots, this is for asteroid hyalosis and frosting on the lattice degeneration of the schisis. So brown solid is for uveal tissue, choroidal detachment, pars plana cyst, or choroidal melanoma, nevus, and also a PED. So brown outline is for the edge of the buckle, which is beneath the detached retina, also for the outline of the posterior staphylogram. Yellow solid for hard exudates, deposits in the RPE or retinoblastoma. This retinal edema is secondary to laser or cryo. Black solid for totally sheathed vessels. Hyperpigmentation in a previous treatment of cryo, and the pigmentation in detached retina. The pigment demarcation line between attached and detached retinas. So black outline is given for this the edge of the buckle in a attached retina. In detached retina, it is brown. Here it is black, and outline of the CRA patch. This is how we depict a small pupil where periphery is not visualized. Let us take a example. Like this is a detached retina, attached retina with the horseshoe tear and lattice with holes. So this is a detached retina. This dotted line shows the shifting fluid level. So this is a detached pars plana epithelium. This can be a vascular lesion like hemangioma. This is showing a flat NVE where it is outlined by blue. This is an elevated NVE outlined by green. So retinoschisis. GRT, where the rolled out flap has a cross blue and the exposed choroid cross red. Macula in attached retina, but there are cysts that is given a blue color. So this idea on documentation, which just needs practice. And thank you for your patience.
Thank you, Dr. Hitashri, for such a wonderful presentation. Indeed, a proper evaluation and documentation is extremely important to arrive at an accurate diagnosis. The next speaker is Dr. Vijay Nagraj. He is from WIMS. He is an associate professor and will be presenting on the management of proliferative diabetic retinopathy. Over to you, sir.
Good morning, everybody. I am very thankful to the scientific committee for giving an opportunity to discuss about the management of proliferative diabetic retinopathy in this PG refresher course. And coming to the presentation. Here, see, I am not going to discuss about the basics, how diabetic retinopathy is there, what is the pathophysiology, all those things I am not going to discuss. Here, the main the questions what are mainly asked in case of proliferative diabetic retinopathy, either it will be a part of a main question or it will be just a 10 marks question. And also, we'll cover a little bit of viva aspect of this management of proliferative diabetic retinopathy also. So 10 marks, it's most of the time it's RGHS, it's a 10 marks question. So whenever a question is asked, you must have a normal outline, what to write. First will be definition, then comes the pathophysiology, clinical features, and management. See, definition, there need not be definition for so many things actually. So you must have your own definitions. You frame your own definitions. Not all definitions are given in the textbook. Either you refer a lot of books and then frame your own definition, but you must have your own definition. So here the definition for PDR is proliferative diabetic retinopathy is characterized by neovascularization originating from the retina under optic disc in patients with diabetes mellitus. Still, you can make it bigger by adding the other symptoms of other signs of complications of proliferative diabetic retinopathy. But this will be enough for the definition. Next comes the pathophysiology. See, I am not discussing about the edema part. Whatever the Kansky that picture is given, basic diabetic retinopathy, I am not going to discuss about that. Here only pathophysiology in case of proliferative diabetic retinopathy. What happens here? There will be 5 new vessels which cross and extend beyond the ILM, often using the posterior eyelid as a scaffold. See, all of us know vitreous is strongly adherent over the optic nerve and along the vasculature. So the new vessels will cross and extend beyond the ILM, and they use posterior eyelid as a scaffold to grow or to increase in size. And also the fibrous component which is present in case of PDR is also mainly from the vitreous only. And most of the time they regress, leaving the fibroscopic tissue that may be tethered with the posterior eyelid. So what are the clinical signs? Here, the main clinical signs here are nevus of the disc, nevusal self-wear, fibroscopic proliferation, pre-retinal hemorrhage, vitreous hemorrhage, and TRD. These are the main clinical signs which are present in case of proliferative diabetic retinopathy. So what you have to write, whether to write how the new vessel arises, all the pathophysics of new vessels. See, you will not write all those things in the theory. What you have to write is mainly what is a new vessel, what's the definition of a new vessel. Okay, in the Viva, there might be a lot of questions like what must be the amount of ischemia to cause new vessels over the disc? What might be the amount of ischemia of the retina to cause new vessels elsewhere over the disc? And also few other questions can be asked. The main question, rare question will be like, without presence of NVD and NVE, will there be neovascularization in the angle? See, all those things are Viva questions. So you can just mention what is a new vessel over the disc, what is meant by new vessel elsewhere. 3 lines or 3 lines, it will be enough for the to write in a 10 marks question. And also fibrovascular proliferation. FEP, I told you, the earlier slide only I told why there will be fibrous proliferation or fibrous component in case of PDR. That 3 lines also we can mention. Then pre-retinal hemorrhage. For that also, pre-retinal hemorrhage can be defined. Where the pre-retinal hemorrhage will be present, between what layers of the retina, or between what layers in front of the retina, between ILM or between posterior eyelid phase, that you have to mention. Only 2 lines will be enough for the pre-retinal hemorrhage also. Vitreous hemorrhage. You need not classify vitreous hemorrhage, what are the types of vitreous hemorrhage, what is intragel hemorrhage and all, but you must know what is vitreous hemorrhage, from where it comes. That's what you have to describe in the clinical signs. Traction retinal detachment. Here you can write descriptively what are the types of TRDs, like tabletop detachment, all the, what are the 3 types of TRDs are there. You can mention that, but you not write the difference of TRD, RRD, and all those things. Just in case of diabetic retinopathy, what are the types of traction retinal detachment is present. So write descriptively, like commonly what happens for the 10 marks question, you can use if you see the RGHS booklet, you can write at least 2.5 to 3 pages. That will be enough to write for 10 marks. 2 pages also is enough to write. So you must frame your timings and frame the answers. So going to the, I'll show you a few pictures of NVD and NVE. See, this is the NVD which is present over the disc, this one, and this the new vessel elsewhere which is present along the infratemporal arcade. This is the picture showing fibrovascular proliferation. What are the red fan-shaped thing you are seeing is the new vessels elsewhere, and what are the grayish-white thing what you are seeing is the fibrous proliferation. In this picture, it is more descriptive. See, this is the optic nerve. Over the optic nerve, there is a fibroscular proliferation along with the sclerosis of the vessel. This is sclerosed vessel. So here there is TRD also. Along with fibroscular proliferation, there is traction retinal detachment also. What is traction retinal detachment? Not that the retina has to be totally avulsed. Even if a small vessel is avulsed or everted or lifted from the retina, even then it is called as traction retinal detachment. What is high-risk PDR? All of us know what is high-risk PDR and its classification. See, whenever there is a new vessel over the disc, which occupies more than 1/3 of the disc diameter, associated with the vitreous hemorrhage or parietal hemorrhage, it is called high risk PDR. And another one is whenever there is a new vessel elsewhere, which is more than 1/3 of the disc diameter, and also parietal hemorrhage or with vitreous hemorrhage, it's a high risk PDR. This is the another picture showing tabletop RD, traction retinal detachment. See, only the central part of the macula is attached here. All over the arcades, the fibrous proliferation is there. Already I told you why there is fibrous proliferation along the arcades, because of the vitreous attachment. Here also other picture also showing the same traction retinal detachment in few places with elevation of the macula. And next comes the investigations part. Investigation part, see, I'll tell you one thing. Whenever you discuss about the management, one is the investigations, another one is the treatment part. In the investigation parts, apart from the systemic evaluation, whatever I mentioned is only the ophthalmic investigations. Apart from the ophthalmic investigations, you have to write some systemic investigations also, like a lipid profile, random blood sugar, HbA1c, and other blood investigations which you normally do. Okay, and apart from the systemic investigation, then go for the ophthalmic investigations like fundus photography, fundus and angiography, OCT, OCT angio, ultrasound, and ERG. You not write all the findings, all the lesions in fundus and angiography also. Just mention few things. Okay, what is fundus photography? Fundus photography, it's a screening tool, like, for the patient's benefit and for our benefit also, to compare the photographs, what was there earlier 3 months back, or whenever the patient comes for follow-up, to compare the old lesions, the fresh lesions. You have to, this fundus photography is used as a screening tool for that. Okay, it is used in diabetic studies, and it is mainly used to educate and explain the prognosis. Legally also, it has got importance. Fundus and angiogram. See, nowadays, due to the advent of this OCT angio and OCT, not many people are using the fundus and angiogram. But even though in few conditions it is used, mainly in case of dense osteodylosis, in case of featureless retina, and to differentiate severe NPDR from PDR, whenever there is a small new vessels which is not clinically seen, and the fellow has got HRPDR and the other eye has got severe NPDR, in case of AAON, macular ischemia, and also to differentiate dilated optic nerve vessels and the diabetic papillopathy. These are the main indications for fundus and angiogram. And this is the fundus and angiogram picture, which is showing new vessels over the disc and new vessels elsewhere. See, there is a profuse lake over the disc and a dark hypofluorescent area, that's a pre-retinal hemorrhage. And what you are seeing is the new vessel. This arrow is showing the new vessels as well. Of course, it's a very small new vessel. And this is a very big C-fan shaped type of neovascularization, which is present along the supratemporal arcade. And what are the dark shadows? What you're seeing is the blood pre-retinal hemorrhage. And this previous picture, whatever you saw, traction retinal detachment, the angiogram of the same patient. See, if you see, the whole thing is the fibroscope proliferation. And one more thing, what you have to appreciate here is, I told you there are some sclerous vessels. Sclerous vessels are not seen here, but here the dark hypoechoic zone, whatever you are seeing, this one is a capillary non-perfusion zone. There is no vasculature here at all. So the more capillary vascular zone, the more will be the density of the neovascularization. That you must know. Next comes the OCT. See, OCT has no role in case of to see the ischemic zones or to see the vascular component. Or OCT had no, only earlier OCT was used only to assess the thickness of the macula. It was the investigation of choice in DME. It has almost replaced the need of FFA, and only it is used for qualitative and quantitative analysis, and also to help the prognosis of visual recovery and to decide on the drug of choice necessary to be given in DME. This is the OCT picture of cystoid macular edema. See, this picture shows the OCT picture also and the angiogram picture also of the new vessel. This picture shows OCT, fundus photo, for angiogram, and the OCT angio, all three together for the neovascularization. Also, this is the NVE in case of angiogram. This is the NVE in case of plain OCT. These three pictures are showing the NVE in case of OCT angio. So, ultrasound. Ultrasound is indicated only in case of dense cataract or vitreous hemorrhage. Sometimes in case of dense cataract, we won't be able to see the whether hemorrhage is there or not. Then ultrasound is used. And also to assess the status of the posterior vitreous detachment, to see presence of traction retinal detachment or retinal detachment in case of diabetic retinopathy, and to assess the macular status. Even the thickness of the macular status can be assessed in ultrasonogram. ERG, very rarely we do, I have not advised any ERG for diabetic retinopathy, but it has got some advantages where abnormalities in the oscillatory potentials of ERG precede the vascular changes in diabetic retinopathy. That's what they say. But ERG, almost the usage in case of diabetic retinopathy is nil. It still remains as a research tool. So after investigations, coming to the treatment part of the proliferative diabetic retinopathy. See, always the gold standard of treatment is laser photocoagulation. Whatever the intravitreal agents, whatever the anti-VEGFs or whatever the vitrectomy, whatever the first and foremost gold standard of treatment is the laser photocoagulation. So what we use here, what is the laser we use? From the argon time to now we are using diode green laser. That's the lasing media what we use regularly. Diode green laser 532. That's what we use. Why? What is the use of this? What it does? What laser does? It's used to induce the iatrogenic choroidal scarring as a treatment option for the proliferative diabetic retinopathy. So how it acts? It acts by conversion of the hypoxic retina into anoxic retina, thereby reducing the release of angiogenic factors. And also, primary mediating factor here is increase in oxygen from the choroid to inner retina due to thinning of the retina. And retinal cells will produce growth limiting factors or reduce production of growth hormone factors in response to laser. What are the indications for laser? According to Etdrs, main HRPDR is the first and foremost indication for the laser. And in case of severe NPDR, if the patient's compliance is very poor for follow-up, then even in case of moderate to severe NPDR and PDR, we do laser. And in type 2, early treatment is beneficial. That time also we do laser. And in case of pregnancy, if the retinopathy is progressing, we do laser. And if the glycemic control is very poor, they say more than 9.5, 10, it's better to do laser in case of moderate, severe NPDR also. This is the picture showing fundus photo with a laser burns. And also the parameters of the laser burns is important. This is a scatter laser burn where power of the laser burn is approximately 150 to 200 watts is used, and the 500 microns is the spot size. One more thing, the spot size. One more thing you must know: relationship between the spot size and the power. Lesser the spot size, the power also must be lesser. Mean size. Power also must be lesser because the penetration will be more if the spot size is less. So if you put a 500 microns spot size, then the power has to be increased because the penetration will be lesser. So always here what they mention is 2 burn width apart, but normally I give 1.5 to 1.5 burn width apart between each ones, 600 to 800 spots in one sitting. That's what we normally do. See, this is the picture of the first sitting and the second sitting. Always you try to do the laser in the inferior part of the retina first, then go for the upper upper, temporal upper, nasal up. But preferably, always it's better to do the first sitting inferiorly. The advantage is that in case if there is a vitreous hemorrhage further in future, we won't be able to do the inferior part of the retina. That's why it's better to cover the inferior part first. Here, the first sitting, here this is how the fundus has been divided into first and second and third sitting. Normally, if the patient is from far place, if the compliance is poor, we finish off the laser in 2 sittings. We won't wait for the 3 sittings. So what are the signs of improvement? The main signs of improvement after 2 or 3 months, there will be disappearance of neovascularization, decrease in the caliber of new vessel, absence of blood flow in the new vessel, and fibrosis around the new vessel. This the picture shows improvement in the signs or recovering phase of the PDR. There are no neovascularization, no fibrous component. Everything is cleared in this picture. When do you advise additional PRP? If there is a new vessel formation, increasing size of the old new vessel, increasing the network and caliber formation, and if there is a fresh vitreous hemorrhage. Coming to the pharmacotherapy of diabetic retinopathy, see there are a lot of studies like WestDR, all the studies are there which have studied on the pharmacotherapy for diabetic retinopathy, but a lot of studies based on this pharmacotherapy are not up to the mark or not give enough evidence to prevent the progression of diabetic retinopathy, but still a lot of physicians prescribe few of the drugs, aspirin, sorbitol, and all few of the drugs they give for the diabetic retinopathy, but it's not a totally complete studies. Anti-VEGF therapy is the present-day therapy. Like normally we give bevacizumab and ranibizumab based on the appearance of the new vessels, whether it is a very big new vessel or whether there is a vitreous hemorrhage. We prefer either of these 2 drugs. And also, bevacizumab is a multi-dose drug, off-label drug. Ranibizumab is a label drug, and even ranibizumab is one more thing. It's a single-dose vial also. So depending on the patient's preference, depending on the clinical findings, we can decide which one to give. It's left to the surgeon's competence. Coming to the vitreolysis, this is very poorly followed actually. Not many people prefer this one in the regular practice. As the advent of anti-VEGF drugs and lasers is more, vitreolysis for PDR is very less. What they do, plasmin and microplasmin, it acts as a recombinant protease with activity against the fibronectin and lamin components of the vitreoretinal interface. Last but not the least is the vitrectomy. Normally we wait for 2 to 3 months for the vitreous hemorrhage to clear. So non-clearing vitreous hemorrhage for more than 2 months and macular traction management, combined mechanism hardy, vitreous hemorrhage with neovascularization, recurrent PH due to vitreous traction, and thickening post-iliad, and these are the indications for vitrectomy of proliferative diabetic retinopathy. Along with that, on the table we can decide during vitrectomy whether to put silicone or not, and endolaser is also part of the vitrectomy. So this basics of the proliferative diabetic retinopathy, and only for the proliferative diabetic retinopathy. Once again, I am thanks for the organizing committee for giving me a chance to present in this forum. Thank you.
For such an elaborate presentation on the most common conditions is Dr. Shashidhar sir. He is a professor in the Department of Vitreoretina at Minto Ophthalmic Hospital, and his topic is vascular occlusion. Over to you.
I'd like to thank organizing committee KOS for giving an opportunity to speak on retinal vascular occlusion. Retinal vasculature comprising an intricate network of arteries, capillaries, and veins that supply the inner retina. Vascular occlusions of retina and their sequelae are the eye are common cause of visual impairment. The prognosis mainly depends on the location, extent, duration, intensity of ischemia in retina. Coming to the retinal vasculature, retinal blood supply is derived from ophthalmic artery, a branch of retinal carotid artery which gives of central retinal artery and posterior ciliary artery, which in turn supplies inner retina and outer choroid. So the outer layers are supplied by the choriocapillaries and inner layers supplied by central retinal artery. So these are the few points to differentiate arteries from the veins. So artery showing wide central light reflux, thin compared to venules. Vascular occlusions are classified into arterial and venular occlusions. Arterial occlusions are central, branch retinal occlusion, ciliary retinal occlusion, combined artery and vein occlusion, and intraretinal ischemic spots. Central venous occlusions are classified into central venous occlusion, branch, and hemiretinal vein occlusion. In central artery occlusion, the blockage is within the optic nerve substance, and the site of blockage and emboli may not be visible ophthalmoscopically, whereas in branch retinal occlusion, the site of blockage is distal to the lamina cribrosa of the optic nerve head. So coming to the epidemiology, incidence is 1 in 10,000 patients, male or twice affected compared to females, and average age of incidence is 60 years, and 90% of the arterial occlusion occurs above the age of 40 years, and bilateral in 1 to 2% of the cases. So etiology, emboli being the most common cause, and other causes are thrombus, inflammation, arterial spasm, and retinal artery dissection. So systemic causes or systemic association with the arterial occlusions are carotid artery disease, carotid valvular disease, vasospasm, GCA, and hypercoagulable conditions like multiple myeloma, sickle cell disease, polycythemia, and protein C and S deficiency, and drugs like oral contraceptions and IV drug users. Miscellaneous causes being compressive lesions, trauma, and surgical procedures. So coming to the characteristics of retinal emboli which causes occlusion, commonest being cholesterol plaques, also known as Hollenhorst plaque, a low refractal emboli located at the bifurcation of vessel derived from or source being ipsilateral internal carotid artery atheroma, and second commonest is calcium emboli. Symptoms: there will be abrupt onset of painless dimness of vision, and few of the patient may present with amaurosis fugax, that is sudden transient loss of vision secondary to transient ischemic attack of occlusion of arteries. Visual acuity ranges from counting fingers to perception of light, and central vision may be preserved in some patients who has intact ciliary retinal artery perfusion. So associated features of occlusions are afferent pupil defect, rubiosis iris, intraocular pressure may be normal or elevated. So classic clinical fundal features are presence of cherry red spot, posterior pole thickening, box carrying of retinal arteries and veins secondary to stagnation of blood flow and separation of erythrocytes from serum. In long-standing cases, attenuation of retinal arteries and optic disc pallor. So this is a fundus picture of left eye showing CIV with cherry red spot. Again, it's a case of CIV with a perfused cerebroretinal artery, and on the right hand side of the screen, right hand side, Holland horse block at the bifurcation of the arteriole. BRAO, that is branch retinal artery occlusion, causes monocular visual loss with a sectoral arterial defect depending upon the site of the occlusion. They may present with a central scotoma. Visual acuity would be better than central retinal artery occlusion. In chronic stages, you'll see arterial attenuation and presence of posterior segment neovascularization. Presence of artery to artery collaterals are pathognomonic signs of branch retinal artery occlusion. Ciliary retinal artery occlusion presents in three distinct forms: isolated, associated with vein occlusion, and associated with anterischemic optic neuropathy. If it is associated with anterischemic optic neuropathy, it's got a poor visual prognosis and needs systemic evaluation to rule out giant cell arteritis. This is a case of BRAO involving the supratemporal quadrant and temporal retina showing paleness or pale thickening secondary to ciliary retinal artery occlusion. So combined artery and vein occlusion shows features of both arterial and venous occlusion. Arterial occlusion suggested by presence of white thickening of the retina, cherry red spot, and dilated venules, multiple hemorrhages are sign, and optic nerve edema, signs of vein occlusion. Coming to the ancillary investigation, fundus fluorescent angiography shows delayed perfusion of the retinal arteriole, variable staining of the optic nerve head, and blockage of dye ahead of embolus. So OCT in acute phases shows hyperreflective thickening of the inner retina, which masks the reflectivity of the outer layer. ERG with severely affected B wave with the characteristic negative wave form. Visual field, central cecal scotoma, arterial defect in branch retinal arterial occlusion. Investigation in giant cell arteritis, ESR, CRP, complete blood count, MRI brain when suspecting stroke, carotid Doppler and echocardiography in case of cardiac abnormality, CT and MR angiogram in suspected case of carotid and aortic dissection. Factor V, protein S and protein C, homocysteine levels in case of hypercoagulable stage. Goals of management is dislodging emboli, reducing intraocular pressure, inducing vasodilatation, and action on thrombus. Treatment has to be initiated within 24 hours. It's experimentally it's known that retinal inner layers can withstand ischemia for about 97 minutes. After 4 hours, it undergoes irreversible damage. So ocular massage using either digital pressure or using 3-mirror gonio lens. Pressure should be applied for 10 to 15 seconds with sudden release, which helps in dislodging the emboli. So reducing intraocular pressure either by paracentesis with the use of topical or systemic antiglaucoma medication, and rebreathing into paper bag attempts to increase the carbon dioxide concentration, and breathing high concentration oxygen with carbon dioxide 5%, that is carbogen, which helps in dilatation of the arteries. Systemic management to reduce the risk factors, and EAGLE, a study, that is European Assessment Group for Lysis in the Eye, which was done to compare effect of intraarterial TPA compared with conservative treatment. Clinically significant improvement was noted in conventional, about 60% improvement, and in case of TPA showed cerebral hemorrhage, hence the warrant the cessation of study. Coming to venous occlusion, central retinal venous occlusion is second most common vascular disorder next to diabetic retinopathy. This is showing site of occlusion in CIVO and branch retinal vein occlusion. Coming to epidemiology, average age of presentation is 65 years. Males and females are equally affected, more common in African ethnicity, mostly unilateral. Risk factors, systemic association of hypertension, diabetes and dyslipidemia, hematological alterations like multiple myeloma, polycythemia vera, etc., ocular disease like primary open-angle glaucoma, pseudotumor cerebri, optic nerve head bruising, and inflammatory conditions which can cause vasculitis like HIV, SLE, syphilis, etc. These factors causes venous blockage, which in turn increases the pressure on the capillaries, which in turn causes endothelial damage and leakage of fluid from blood into the retina. Stasis of the flow, change in the vessel wall, and hypercoagulability can cause thrombosis, in turn which causes occlusion of the vessel. Symptoms: there will be insidious onset, painless loss of vision, pain, redness if there is associated neovascular glaucoma. Visual acuity presentation would be variable, starting from hand movements to near normal vision, depending upon whether it's a perfused or ischemic occlusion. Associated afferent pupillary defect indicates ischemic CRVO. It's a classic fundus feature showing hemorrhages in all 4 quadrants with dilated tortuous vessel. It's called blood and thunder appearance, cotton wool spots, and in long-standing cases you will see optociliations and neovascularization over the disc and elsewhere. This is again a fundus feature showing multiple hemorrhages and cotton wool spots with dilated tortuous veins suggestive of vein occlusion. So 80% of the cases present with non-ischemic type and 20% would be ischemic, and over a period of time 20% of non-ischemic will turns into ischemic type. So classical findings are grossly reduced vision, presence of RAPD, site of occlusion would be retrolamellar in ischemic, and marked disc edema, and on FFA perfusion CNP areas would be more than 10 disc diameter in case of ischemic. Prognosis will be poor in case of ischemic compared to non-ischemic occlusions. Coming to BIO, most common type of vein occlusion. Common quadrant involvement is supratemporal, sudden painless dimness of vision involving the sector corresponds to sector of occlusion. This is a picture showing supratemporal vein occlusion with multiple hemorrhages beyond the site of occlusion, giving an appearance of splashed tomato appearance. So ischemic BIO is considered when CNP on FFA would be more than 5 disc areas. This is the macular tributary vein occlusion, and on the right hand side of right hand is view showing branch retinal vein occlusion beyond the site of occlusion. See lot of hemorrhages. Hemiretinal vein occlusion occurs in 2 variants, that is hemicentral and hemispherical. Hemicentral if the vein divides into 2 trunks before entering into the lamella cribrosa, and if one of the divisions of the central vein occludes, whether either superior or inferior, it's called hemispherical vein occlusion, being the least common, and neovascularization is known to more common in case of HIVO than BIVO, but less common than CRVO, so hence needs frequent follow-up. Coming to fluorescent angiography, there will be delayed filling of the veins and areas of CNPs clearly made out, and failing of smaller vessels filling, which is called pruning, which will be well appreciated. And here is the hyperfluorescence, which increases in late phases, suggestive of presence of neovascularization and macular ischemia. OCT shows cystoid macular edema. Visual field, multiple scotomas in an affected area, and these are the few investigations which requires an atypical, that is if the presentation is less than 40 years. These are investigations which are supposed to be done in case of vein occlusion. Complications of vein occlusions are vitreous hemorrhage, traction detachment, neovascular glaucoma, submacular fibrosis, and persistent macular edema. Treatment goal: treat associated intraocular neovascularization, and treatment of macular edema either by VEGF or corticosteroids. And it's known that visual acuity in macular edema does not improve with grid laser in case of CRVO, but helps in case of branch vein occlusion, and in case of neovascular glaucoma or primary open glaucoma, reduce intraocular pressure and treat the underlying conditions. So treatment options are intravitreal anti-VEGF requires ranibizumab 0.5 milligram per 0.05 ml, and intravitreal corticosteroid and macular laser. Treatment of neovascularization by panretinal photocoagulation in case of CRVO, and in case of VRVO, which is showing neovascularization elsewhere, can be managed with scatter laser and adjuvant intravitreal anti-VEGF. These are the other treatment alternatives. If it is associated with vitreous hemorrhage or attraction detachment, patient may be subjected to vitrectomy and follow up in case of CRVO every month for the first 6 months, and then biannually. In non-ischemic CRVO every 3 months, and every 3 months till the first 6 months, and then annually. See, these are the few studies which shows help of scatter photocoagulation or panretinal photocoagulation in prevention of branch vein occlusion study and central vein occlusion study show the importance of laser in treating macular edema. It helps in case of branch vein occlusion, where in case of central retinal vein occlusion doesn't have any role in reducing the macular edema. Other studies are SCORE study, which was done in 2004, which compares intravitreal triamcinolone to standard conventional therapy for vein occlusion, either CRVO or BRVO. So macular edema reduced in case of significant macular edema, but does have vision-threatening complications of cataract and glaucoma. So other studies related to anti-VEGF are BRAVO and CRUISE, which shows the efficacy of ranibizumab in treating macular edema. Geneva, it is shows the efficacy of dexamethasone, that's an intravitreal implant in treating macular edema. Copernicus and Galileo are studies related to intravitreal VEGF trap, that is aflibercept, in treating macular edema. So few conditions which should be differentiated from the vein occlusions are ocular ischemic syndrome and diabetic retinopathy. These are the features. You can look into type of hemorrhage and whether dilatation is there or not, presence of microaneurysm, and FFA features. Thank you.
Such presentation was very informative.
Now we call upon Dr. Ravi.
Next will be Ravi sir. He is an assistant professor here at Minto Ophthalmic Hospital, and his of fundus fluorescent angiography and optical coherence tomography.
Good afternoon. I'll be talking about interpretation of FFA and OCT. OCT is nothing but a non-invasive, non-contact imaging technique which gives us an high-resolution cross-sectional retinal images, which is nothing but optical biopsy. Started in 1991. Based on the principle of low coherence interferometry, where multiple A scans are taken and which combine to give a B scan image. So A scan gives us a B scan, and multiple two-dimensional scans are used to construct a three-dimensional scan. So broadly, time domain OCT and spectral domain OCT. Time domain OCT uses a movable reference mirror. It takes only 400 scans per second. It takes a longer time and a lesser resolution compared to spectral domain OCT, which uses a fixed mirror and which scans at the rate of 40,000 per second. So lesser acquisition time and better resolution, as you can see in the image. Further advance is step source OCT, where we can image the choroid also. So now the more and more work is being done in this field. So there are various image acquisition protocols like a line scan, macular cube, which measures 6 mm into 6 mm, raster line scan, and a radial scan. Quantitatively, we can analyze the thickness of the retina. This is a resolution of various imaging modalities. There is a false color coding for depicting the structures based on the reflectivity. The structures with more reflectivity like RPE, chora capillaris and nerve fiber layer are depicted in the warm colors towards the red side. Whereas structures with the lesser reflectivity like photoreceptors, nuclear layers and any fluid like intraretinal fluid or subretinal fluid are represented in cool colors, that is towards blue. So then there are various uses of OCT, right from the understanding the disease process, a diagnosis, prognosticating a case and a follow-up. So this is a normal OCT showing all the layers of the retina, right from the choroid till the internal emitting membrane. So there is a newer nomenclature for the OCT, which added a few other entities like a myoid zone and an ellipsoid zone and a interdigitation zone. So which is mainly focusing on the photoreceptor segment. Coming to the analysis of a retinal OCT. So broadly, we analyze on the following headings like an retinal interface, foveal contour, retinal thickness and retinal configuration, and RP choroid complex. So whenever there is an OCT image, we have to try to analyze in following like categories. So coming to the uses of OCT in various retinal diseases, since the diabetes is one of the common diseases we encounter, so we have to know about this entity. We have to, what are the uses? There is a presence and the area of the retinal thickening. How close to the center of the fovea there is a thickness, which in turn indicates the severity of the condition. More close to the fovea, then more visual disability. Then you can also categorize based on OCT into 5 types, that is spongiform macular edema, cystoid macular edema, serous macular edema. This is a diffuse thickening or a spongiform macular edema. This is a case of serous where there is a subretinal hyporeflective suggestive fluid along with the intraretinal hyporeflective suggestive cysts. You can see an incomplete PVD. Then this is a cystoid macular type of macular edema. We can see intraretinal cysts. This is a taut posterior head where there is a thickened posterior along with the retinal irregularity or a distortion along with the retinal thickening. This is a vitreomacular traction where there is a posterior halide is attached to the fovea, causing a tenting. Cystoid macular edema can also be caused by other conditions like an uveitis, post-cataract surgery, or a vein occlusion. So cysts with retinal thickening is called cystoid macular edema. There is an entity called macular telangiectasia or idiopathic parafoveal telangiectasia, where there is a cyst-like structures in the retina. However, the retina is not thickened, so the foveal contour is maintained in this condition. The cyst this year, it is actually not cyst; they are like lacunae in the retina because of the degeneration. It doesn't need any treatment. So this is a case of a CSR with ink blood pattern of leak showing a subretinal fluid accumulation. This is called neurosensory detachment. So this is another case of CSR with neurosensory detachment along with pigment epithelial detachment, PED. So this is a case of optic disc pit with serous macular detachment. You can see here there is a cystic cavity in the retina along with some subretinal fluid, and there is a connection to the optic disc. This is another case of disc pit with serous retinal detachment. This is a case of retinocysis with there is a splitting of the nerve fiber layer with septations. So clinically, it shows an honeycomb pattern or a spoke wheel pattern. So then the role of OCT in ARMD. You can see here there is a subretinal deposition of drusen. So on OCT, you can see there is an elevations in the retinal pigment epithelium with hyperreflective material suggestive of a drusen. This is a case of geographic atrophy on OCT showing a retinal thinning. This is a case of cottonwool spots where you can see there is a hyperreflectivity in the nerve fiber layer corresponding to the cottonwool spot. This is a case of art exudates where you can see an hyperreflectivity in the outer flexiform layer along with backscattering. This is again showing drusen. So this is a OCT showing differentiation of a pseudodrusen from a true drusen. True drusen deposits under the RP, whereas pseudodrusen deposits over the RP. So PD can be divided on OCT based on the material accumulation. That's a drusenoid PD, fibrovascular PD where there is a fibrovascular complex. So here you see a double layer sign. In case of hemorrhagic PD, there will be elevation of the RP along with accumulation of bleed. So it also causes backscattering. Then there is a serous PD. So fibrovascular PD and hemorrhagic PD, they usually associated with active CNVM, whereas a drusenoid PD usually suggestive of an ARMD, which can lead to dry RMD, which can lead to wet RMD, unfollowed. Then based on OCT, we can divide the CNVM into type 1, type 2, and type 3. Type 1 is sub RP, neovascular complex, along with the neurosensory detachment, along with the subretinal bleed. Type 2 is subretinal or above, the neovascular membrane is above the RP. So here you can see neurosensory detachment along with intraretinal cysts and subretinal bleed or neovascular complex. RAP, that is type 3, that is retinal angiomatous proliferance. There is a disorganization of the outer retinal layers along with intraretinal cysts. Then this bottom image is showing a healed or a scarred CNVM. There is an subretinal hyperreflective membrane along with intraretinal cysts and a outer retinal tubulation, which indicates chronicity. This is a case of CNVM with subretinal fluid. After treatment of photodynamic therapy, there is a complete resolution of the fluid. This is a case of CNVM, active CNVM with the subretinal bleed and neurosensory detachment. After injection bevacizumab, there is a complete resolution of the fluid and the bleed. So OCT has an immense role to play in the diagnosis, prognostication, and follow-up of macular hole. This is a case of full thickness macular hole before and after the macular hole surgery, where there is a continuous ISOH line, which indicates a good prognosis. So various indices like macular hole index, hole form factor, diameter hole index, and tractional hole index. So this is a case of lamellar macular hole. There is a discontinuity of the inner retinal layers. However, the outer retinal layers are intact. So there is a mild ERM in the nasal aspect. This is a case of epiretinal membrane where you can see the thickened posterior hyaloid along with the retinal thickening, and there is an wrinkling of the inner retina. So this is a case of a mild ERM. This is a case of an ERM with a pseudo hole where there is a squaring of the edges in case of an pseudo hole. So this is a grade 2 ERM. There is a macular pucker. So there in vein occlusion, we can see cystoid macular edema along with some intraretinal hemorrhages. OCT in case of hereditary fundus dystrophies, in case of retinal pigmentosa, there is cystoid spaces in the retina. And in case of Stargardt's and cone dystrophies or bullseye maculopathy, there will be foveal thinning along with loss or discontinuation of the ISOS or a photoreceptor layer. Then there are various newer OCTs like an intraoperative OCT, NFAS OCT, and a swept source OCT. Coming to the fundus fluorescent angiogram, this is nothing but a photographic surveillance of the passage of the fluorescent dye through the retinal and choroidal circulation. Fluorescent is a property of the certain molecules to emit a light of longer wavelength when stimulated by a light of shorter wavelength. So it responds between 465 to 490 nanometer light, that is a blue light, and it fluoresces at 520 to 530 nanometers, that is yellow-green light. So 80% of the 80% is bound to the proteins. Then the free form of the sodium fluorescein is 20% is available for fluorescence. Normally the choroidal vasculature has fenestration, so it can dye leak through the choroidal vasculature. However, Since there are tight junctions between the RP and there is no penetrations in the retinal capillaries, they doesn't normally leak. Only when there is a pathology, when there is a disruption of the barrier or when there is a capillary damage, only the dye will leak. So coming to the technique, a patient is pupil is dilated and nil per orally at least 1 to 2 hours is a must. Informed written consent should be taken. Patient should be accompanied by a attender. Red free and a color photo is taken before the procedure. So before injecting, as soon as you inject a dye, you have to take an image that is at a 0 time. Then photograph is started at 8 to 10 seconds after dye injection. Then you repeat every 1.5 to 2 second interval till 30 seconds. Then you repeat at 1 to 2 minutes. Then you can take late phase at 6 to 8 minutes. So if you are suspecting leakage occult CNVM, then you can take images at 10 to 12 minutes also. That is a late phase. First images, early images have to be taken in the eye where pathology is suspected than in a normal eye. So coming to the phases of angiogram. So as we all know, there is a pre-arterial phase or a choroidal phase, which occurs at 10 to 12 seconds after the injection of the dye. You can see here there is an hyperfluorescence in the choroid. However, the retinal vessels are not filled. But there is one vessel which is filled here. This is ciliaretinal artery, which is in around 20% of the normal individuals. So it is filled before the retinal vessels because it is supplied by the choroidal vasculature. Then comes an arterial phase, which comes 1 to 2 seconds after the choroidal phase, where you can see retinal artery is getting filled. Then the early arteriovenous phase, where there is a complete filling of the arteries and capillaries. Now the laminar flow along the vein walls. You can see there is laminar flow along the veins. This is a case, this is the early venous phase where there is a complete filling of the arteries, capillaries and with more prominent filling of the veins, which occurs at 30 to 35 seconds. Late venous phase, which occurs at 30 seconds to 2 minutes, where the dye starts draining from the arteries and slowly starts from the veins also. So there is a recirculation phase or elimination phase where there is a most of the normal there is a elimination of the dye from the veins also, which occurs by 10 minutes. So and there is staining of the disc and sclera in this phase. This is a normal fundus photo, fundus FFA image of a right eye, showing there is a slow gradual tapering of the vessels in the macular region and leading to no vessels or foveal avascular zone in the central 300 microns. This is a FFA of a right eye in a diabetic patient, showing an abrupt ending of the vessels in the foveal area, along with an enlarged foveal avascular zone, along with multiple hyperfluorescent dots suggestive of micronisms and a neovascularization showing a leak in the temporal aspect of the macula. So this is a case of macular ischemia along with neovascularization, which is suggestive of a proliferative diabetic retinopathy. So coming to the abnormal patterns, it can be hyperfluorescence and hypofluorescence. Hyperfluorescence means there is a more leakage of there is a hyperfluorescence means more brightness. Hypo means dull. Okay, so it can hyperfluorescence can because of the pre-injection, that is autofluorescence, which is seen in optic nerve drusen and astrocytic hematoma. Whereas pseudofluorescence occurs because of the overlapping of the filters, both barrier and excitator filters. So that's why we have to take red-free filter photograph before injecting the dye. Then abnormal fluorescence, there are 4 patterns, that is window defect, leaking, pooling and staining. So window defects are transmission defect is because of the focal RP atrophy or an absence or a normal background choroidal fluorescence is unmasked. That means the choroidal fluorescence is seen better when there is a loss of RP. So early hyperfluorescence that increases in intensity then fades without changing the size or the shape. In case of pooling, which can occur in case of CSR or a RP detachment, here the hyperfluorescence increases with intensity, but the size will be the same. You can see here, there is an hyperfluorescence in the early phase, which increasing in intensity. However, the size is the same. Unlike in case of leakage, where there is increase in the intensity of the fluorescence along with the size. So that can be seen in case of a CNVM or a cystoid macular edema, or in case of a any neovascularization. This is a cystoid macular edema showing a petalloid pattern of leak. This is a case of CSR showing smokestack pattern of leak. This is a case of proliferative diabetic showing a neovascularization of the disc and a macular ischemia. This is a case of BRO with neovascularization showing a leak in the infratemporal quadrant. This is a staining pattern of leak, staining pattern of hyperfluorescence, which is a case of healed choroiditis. Then hypofluorescence, it can be because of the either blockage or because of the vascular occlusions. So blockage, any vitreous or a pre-retinal bleed will cause blockage. You can see in the color photo, there is a hemorrhage along the adjacent to the disc, corresponding FFA showing an hypofluorescence. So this should not be confused for CNP areas. So blockage also can be caused by blockage of the choroidal fluorescence can be caused by subretinal or sub-RP lesions, because of any pigmentation or any choroidal lesions. Then hypofluorescence can also be caused by pilling defects like a vascular occlusion or a loss of capillary bed or a capillary occlusions. So this you can see in case of vein occlusion, infratemporal vein occlusion, there is a capillary non-perfusion areas. So we should, one more take-home message is you should always compare fundus fluorescent angio photo with a clear color photo and OCT with a color photo. Never interpret alone. Thank you for your patience listening.
Thank you, Dr. Ravi. Quite a basic diversity. Next, I would like to call upon Dr. Hemlata BC, Assistant Professor at Minto Ophthalmic Hospital. Her topic is evaluation of a case of retinal detachment. Over to you, ma'am.
Good afternoon. Today my topic is on retinal detachment. I would like to thank KOS Scientific Committee, Dr. Ellen Kumar sir and Nagra sir for giving me this opportunity. The retinal detachment, as we all know, can be broadly classified into rhegmatogenous retinal detachment and non-rhegmatogenous, that is either tractional or exudative retinal detachment. So the pathogenesis is mainly the vitreous, which is very strongly densely adherent to the vitreous base, peripheral retinal degenerations, either snail track degeneration or lattice degeneration. So whenever there is a PVD, as you see here, the poster which has been removed from the wall, there is a thick adherence, so part of the wall material comes as well. So there will be tears or hole formation in the peripheral retina, which may lead to retinal detachment, especially thin retina like in myopes. The incidence of bilateral RD is around 5 to 10%. Thus, the predisposing factors being the peripheral retinal degeneration and a PVD, but in 85% of the patients, the PVD uneventful, whereas in around 10 to 15%, it may be associated with retinal tear, hemorrhage, and retinal detachment. Very rarely, there may be only the avulsion of the blood vessels leading to vitreous hemorrhage. It's always important to see what's happening in the other eye before we start managing the RDI, because there may be some peripheral retinal degenerations like lattice degenerations, or maybe there is a retinal hole or a fresh HST which has to be prophylactically barraged to prevent RD in these eyes. So a fresh RD, how do a fresh RD appears? In the slit lamp anterior vitreous, you may see the tobacco dust appearance. This is called a Schaffer sign. Along with the basic evaluation of visual acuity, pupillary examination to look for RAPD, it's very important to look for the fellow eye intraocular pressure, because always the IOP will be lower in the RD eye compared to the fellow eye. So this is the fundus picture of an RD where you see there is convex elevation and it extends up to ora serrata, the detachment, the blood vessels appears darker, the loss of the choroidal pattern, and this is the retinal break. So how do a patient present? Initially with only tears or an operculum, you may see floaters like this, or a flashes of light with active HST or traction over the HST, so mechanical stimulation of the photoreceptors. Once the RD set in, then there will be distortion of the field of vision along with black curtain-like appearance as seen here. And even the black spots number increases significantly. And a fresh RD, we should always see for the corrugation as seen here. And if there is a doubt about the macular involvement, you can go for an OCT. Here there is a fresh RD just involving the fovea. And this is a picture of long-standing RD, where usually an inferior RD, you may see a watermark sign. This is the demarcation line, multiple subretinal bands. And there may be a cyst which can be easily picked up with a B scan, and OCT, there will be significant thinning of the fovea. PVR classification, this is grade A, grade B, retinal wrinkling with rolled edges of the tears, and there will be rigid retinal folds with dense vitreous condensation and strands. Coming to tractional retinal detachment, which will be dealt in the next talks, the main pathogenesis here is the fibrovascular proliferation due to extensive neovascularization. So initial there will be tangential traction, then an anteroposterior traction, and between the arcades, that is the bridge traction. So the fundus appears concave retinal detachment, which is immobile, highest at the site of vitreoretinal traction, and it is slow in progression with variable amount of fibrosis and does not extend to ora serrata. Management, we need to find all the breaks with a careful retinal examination and create a chorioretinal scar for adherence of the break. We can apply the Linkoff rule to diagnose the retinal breaks. So inferior RD usually at 6 o'clock, very bullous RD inferior, the break will be superiorly and small, and subtotal RD, usually the breaks will be 1 to 1.5 clock hours from the attached to detached retina. Most common site of breaks is superiotemporal quadrant, around 47%, and macular hole also can lead to RD, although rare, 0.5 to 1%. The macular hole in an RD with peripheral breaks, 2 to 8%. So keeping in mind about the PVR classification, accordingly we have to plan the treatment. Pneumoretinopexy, the success is good if the patient selection is good, like a fresh RD, superior 8 clock hours, single break or a cluster no more than 1 clock hours, and the patient should maintain the position. And very important is not to miss the secondary breaks, which were seen in 53% of the eyes, either on the on retina or an off retina. With due respect to all the pioneers who have extensively contributed for the buckling procedure, the main indications of scleral buckles are anterior breaks, young patients, traumatic dialysis, myopic eyes with fresh RD. The explants which we use are symmetric, that is 279, asymmetric 276, and sponges rarely because the incidence of infection is high. And a scleral buckling is an art surgery where all the breaks has to be recognized and the posterior most break has to be well supported in the band so that the success is good. So this is a short video of scleral buckling procedure. This is the scleral tunnel made, crescent blade, and belt buckle secured with a Watsley sleeve, and scleral sutures were replaced, and then the 279 scleral buckle was placed. 30 gauge needle was used for drainage of SRF. After complete drainage, we can increase the indent of the buccal, and finalize the sutures. And this is the pre and the post pictures of the buckling procedure. Coming to vitrectomy indications, mainly it is giant tears as shown here, or it is the PVR dens involving the posterior pole, retinal detachment associated with choroidal detachment, a huge HST with active traction, a large inferior breaks, and a retinal breaks multiple involving the posterior pole and macular hole associated retinal breaks. So this is a short video about vitrectomy procedure. In this patient, because there was a large break inferior with long-standing trauma was the etiology, we planned for a buckling procedure initially, 279, followed by vitrectomy, and there is PVD induction using triamcinolone to stain the vitreous. Securing the posterior pole with the PFCL, and this is endocautery being done to the edges of the break, and all the vitreous adhesions to the break has to be removed. Fluid air exchange, PFCL removal, endolaser which is being done, followed by silicone oil injection. The prognosis is good if the macular detachment is within 24 hours. Coming to exudative retinal detachment, how do a patient present? The patient usually presents with red eye, decrease in vision or a field defect, pain if it's associated with scleritis, or white reflex, especially like Coats disease. It is very important not to miss the slit lamp examination to look for inflammatory cells in the anterior vitreous, and the retina is characterized by a smooth surface that lacks the folds as seen in rhegmatogenous retinal detachment. B-scan helps to diagnose the shifting of the fluid. There are the various causes for exudative detachment. It can be choroidal tumors, intraocular inflammation, toxemia of pregnancy, excessive laser, or choroidal neovascularization. The fundus appears convex, smooth elevation, may be very mobile with the shifting of the fluid, and once the SRF resolves, you see extensive damage of RP cells, so leopard spot appearance. B-scan plays an important role in an exudative RD to diagnose any choroidal tumors, and if there is any choroidal detachment or the thickness of the sclera, to know for the T sign as in posterior scleritis, small eye, nanophthalmic eye, vitreous inflammation, infiltration. As shown here, this is the pre and the post treatment of methotrexate for a lymphoma patient. The other which we come across commonly, VKH and multifocal CSR as seen here, active and once treated. Uveal effusion syndrome, the leopard spot appearance with SRF here. OCT confirmed the foveal detachment, and the patient underwent scleral window which is being done by removing the partial thickness of the sclera. So here there is complete resolution of the SRF. The main differential diagnosis of RD are degenerative retinoschisis, choroidal detachment which will be dome shaped and brown in color, uveal effusion syndrome. This is to summarize the salient features of Reg RD, exudative RD and TRD. Thank you. The sooner the better, and the early treatment we can always get a good vision. I again would like to thank Dr. Ellen sir for giving me this opportunity. Thank you.
For such a brilliant presentation. Videos that ma'am showed were very informative. I really thank you, ma'am. Next is Dr. Rajpal. Its management. He is a consultant and Uveitis specialist. Over to you, sir.
Good afternoon, everybody. I am Dr. Rajesh Babu from IST Hospital, Devnalli. Thank the organizers, especially Professor Nagraj, for giving me an opportunity to present my expertise in uveitis. As we all know, uveitis is a subspecialty of ophthalmology that treats inflammation and infectious disease affecting the eye. Most of the disorders are immunological in nature, and a fairly good knowledge of immunology, internal medicine, rheumatology, dermatology, pulmonology is imperative to understand these various disease processes. It's very important for us to understand that uveitis is not only inflammation of the uveal tract, but also adjacent structures like retina, optic nerve, sclera, cornea, and vitreous. And intraocular inflammation and ocular inflammatory disease is a more apt term to describe these entities. Some of these diseases are fairly benign in their effect on the eye, and some of these are visually devastating, like Behçet's disease. Some of these affect multiple systems, leading to their failures over the course of disease. And some of these diseases can affect only the eye, like pars planitis or sympathetic ophthalmia. So what do we do when we see a case of uveitis? 4 questions to be asked. Is it an uveitic or non-uveitic entity? What parts or parts of uvea is involved? What's the stage of the disease? And what's the cause of the uveitis? This is the case of a 8-year-old girl, no pain, no redness, white hypopyon, an aqueous tap revealed presence of malignant cells, which confirmed the suspicion of retinoblastoma. Subsequent enucleation confirmed presence of diffuse anterior infiltrating retinoblastoma. This case was not at all an uveitic entity. Here is a 38-year-old lady with no pain, no redness, hypopyon, but with patchy iris atropine holes, and AC tap revealed inflammatory exudate with migrating microfilarial worm. The case of a 70-year-old lady, decreased vision, pain, vomiting, headache, invariably leads us to suspect a lenticular etiology, lens-induced glaucoma, or phaco-anaphylactic glaucoma. Mimicking anti-uveitis. These 4 entities should be remembered and always ruled out before initiating treatment. Conjunctivitis, scleritis, episcleritis, acute angle closure glaucoma, and Muscular syndrome. We all know the symptoms of anti-uveitis, some of which may coexist with the posterior segment inflammation or intermediate uveitis. So, posterior segment involvement invariably causes severe visual loss or metamorphopsia or floaters, and antisegment, and then there may be spillover antisegment inflammation along with this. 2 entities like endogenous endophthalmitis and large cell lymphomas should be ruled out because these are masquerades which can cause life-threatening disorders in the patient. ARMD or disciform scar in ARMD is non-uveitic entity which can often confuse an inexperienced doctor. Should also remember central serous retinopathy, posterior scleritis, and ARMD, which can have signs and symptoms related to uveitis. Posterior scleritis with diffuse choroidal folds, which can only be confirmed by B scan. The clinical approach of uveitis. Step 1 is uveitis-oriented history, complete eye examination, identify the anatomic location of uveitis, external examination. Uveitic-oriented history should be detailed, documenting the onset, course, symptoms, laterality, treatment given, response to treatment, and associated systemic disease. And very important to know classification of uveitis, because uveitis may or may not be localized to one part of the uveal tract, can be caused by infectious disease as well as autoimmune process, or both can simultaneously occur. This can be part of a systemic disease, and uveitis can masquerade non-uveitic conditions. Very important to remember all the definitions and classification. I will not be going into details of this due to paucity of time. So the clinical classification of uveitis should have the duration and onset, that is acute, chronic, recurrent. Is it active or resolved? Is it a granulomatous or non-granulomatous entity? Is it mild or severe entity? Or is it a simple or complicated entity? You should remember the course: acute, chronic, and acute recurrent. So this case of HLA-B27 related uveitis, well-defined onset, acute onset, severe pain and injection, fine capies, no iris nodules, but segment is rarely involved. It's a sarcoid granulomatous uveitis, insidious onset, chronic course, pain and the injection are mild, iris nodules are present, button fat capies and pulse segment is commonly involved. Intermediate uveitis is also called process cyclitis, hyalitis, or basal retinochoroiditis. Very important to examine the inferior pars plana to rule out snowball exudate and inferior snow banking and vitreous or pars plana membranes. Posterior uveitis can present as focal, multifocal, diffuse choroiditis, chororetinitis, retinochoroiditis, neuroretinitis, and frank retinitis. In this case of toxoplasma retinochoroiditis, retinal whitening with overlying vitritis and deep choroiditis. So active chororetinitis. It's a case of acute retinal necrosis characterized by retinal whitening and hemorrhage and vascular occlusion due to the vasculitis process in necrotizing herpetic retinopathy. Case of acute CMV retinitis involving the posterior pole. Note the involvement of blood vessel as well as the retina, because CMV is a neurotropic virus. It's classic pizza pie appearance. Retinochoroiditis affecting the posterior pole, causing macular edema as well as disc edema. Then deep choroiditis with no overlying retinal involvement. It's neuroretinitis. It's a leptospira associated inflammation of the optic nerve head as well as overlying vitreous and macular edema. It's a neuroretinitis. String of pearls appearance in sarcoidosis. Multifocal choroiditis, diffuse choroiditis, serpiginous choroiditis. You can see active as well as healed. You can note morphological differences between active and healed. Sympathetic ophthalmitis, not the sympathizing eye, not the complications in the sympathizing eye as well as the exciting eye. Toxocara scarring, leading to posterior segment complications like retinal detachment, tractional retinal detachment, and disc heterotopia. Deep retinal abscess due to tuberculosis. Important to examine externally. Skin lesions, especially in India, Hansen's is very important to be ruled out. Important to rule out spinal deformities in any patient with acute anterior uveitis, young age. Episode indicates immunosuppression due to any cause, notably HIV. Subpart skin lesions are very important, not to be missed. Easy to biopsy, easy to initiate treatment, specifically targeting the systemic sarcoidosis. Step 2, compare clinical characteristics of what we see with non-uveitic entities. Shortlist etiologic possibility and initiate therapy. Tailored investigations. Cannot do all the investigations what is described in textbook because of the economics involved in doing a detailed examination. Specialty consultation. Hit early, initiate therapy, hit early and hit hard. Modify and modify treatment, assess and treat complications. In summary, history, ophthalmic examination, anatomic classification, systemic evaluation, investigation, etiologic classification, and management. I'm not going to details of management. That's a different talk in its own. So it's very important to know that a totally empirical approach is not to be taken in all cases. A totally lab-dependent approach is not to be taken in all cases. We have to follow a middle path in our country because of the economics involved. Most importantly, always instill hope in patients and remember, do not do any harm. Thank you.
Thank you, Dr. Rajesh Babu, for the beautiful talk and beautiful presentation. On behalf of organizing committee KOS, I would like to thank all the speakers, Dr. Hitashri, Dr. Ravi, Dr. Vijay Nagaraj, and Dr. Hemalata, and Dr. Rajesh Babu, their time and a beautiful presentation. I'd call Dr. Ravi to talk on any points to be added.
So it's very, very important. I will be discussing about the vascular occlusions. So it's very important to differentiate between a vein occlusion and an arterial occlusion. So in arterial occlusions, usually we don't get hemorrhages. Only there will be retinal ischemia. So we'll be whitening of the retina. So in arterial occlusions, we have to rule out systemic diseases like an hypertension and a cardiovascular disease. So in case of vein occlusions, you will see there will be, because of the vein occlusion, there will be back pressure and there will be hemorrhages like a dot blood and a sphincter hemorrhages along with macular edema. So this can either it can be branch or an central retinal vein occlusion. So this needs treatment. Along with the ocular treatment, we have to also look for systemic conditions like an hypertension. In younger patients, we have to look for homocysteine levels. And we have to timely manage with a pharmacotherapy or a laser treatment. Thank you so much.
The management of diabetes already talk. I would like to add practical points while delivering the laser. So you should keep in mind what type of lenses you are using, because magnification factor you have to keep in mind. So they say that 500 micron size, but when you're using mainstream, so you have to keep it 250 to 300, so that expansion factor you should keep in mind. And for the management of diabetic vitrectomy, so anti-VEGF can be used as adjuvant before planning for surgery, so that you can avoid intraoperative bleeding. And in case of managing with diabetic retinopathy, you have to do, as sir told, inferior laser to the inferior part, and then plan for diabetes, so that if the patient has got any macular edema, you can go ahead with a grid laser or focal laser. Thank you.
All the speakers have in their best to teach the postgraduates the evaluation of fundus. So all the postgraduates should learn IDO now. Direct ophthalmoscopy has become almost an COVID time. So you will be bound to go IDO to see the fundus. So do your best to periphery so that you don't miss any retinal lesions. So Dr. Hema and Dr. Hitesh have stressed on the evaluation of RD. All the postgraduates, everyone, all of us should try to look for the breaks. Indenting. Management depends on the finding all the managing and sealing this break. Then only the surgical outcome will be good. So even in a busy OPD, if you have any doubt, please give some time to such patients whose vision and clinical findings, at the first go are not correlated. See up to the periphery. Anterior segments, lamp and IVO should be done in these cases so that we don't miss anything and patient don't come late and management will be difficult. I like to conclude the session. Thank you.
The next session will be the KR Murthy PG quiz, which will be hosted by the quiz master, Dr. Vidya Ishwaran and Dr. Shweta M. To participate the quiz, you will have to download the Kahoot app and log in. And this app will not be working on MacBook, but it's available on iPad. The quiz will be starting exactly at 4 p.m. Till then, I would like to take the time to convey my heartfelt gratitude to the COSCON team for taking the time and effort to create a teaching platform which is accessible to all our postgraduates. This virtual conference has made it possible to culminate knowledge from best teachers all over the state and enlighten the young minds of budding ophthalmologists. I would like to thank all the guest speakers. From the cataract module, I would like to thank Dr. Shilpa Kodkani, Dr. Soumya Armurthy, Dr. Savio Pereira, Dr. Manjunath. From the cornea module, I would like to thank Dr. Nagraju, Dr. Deepthi Armeda, Dr. Ilan Kumaran, Dr. Tanuja GP, and Dr. Kiran Kumar. I would G.S. Gopinath, Dr. Dr. Gopal, Dr. Harpra.
Unable to hear you, Diksha. Diksha, no voice. You're muted. I think they're facing a technical difficulty right now. On behalf of COSCON, the scientific committee, I would like to thank the exemplary work done by Minto Eye Hospital and Regional Institute of Ophthalmology, particularly Dr. Nagaraju sir and all other faculty there, and all those who presented. This was an auspicious beginning to the COSCON 2021 conference. The next 2 days, starting from now, is packed with almost 100 sessions, each one with around 7 lectures each. I request all of you to attend it. In another 20 minutes, Dr. Nagaraju sir and his team has compiled a beautiful quiz. This is Dr. KR Murthy PG quiz that we conduct every year. I request all the postgraduates to attend this quiz. I request the event management team. Jyoti, yeah, please. Okay, thank you. Thank you.